Well, welcome everybody to November 15th. Today we have a very special webinar for you. This is focused on the NAPBC and patients with breast cancer. This is Asa Carter. I am the Senior Manager for Education and Training in Cancer Programs, and I am very pleased to be able to welcome you to our webinar today, Helping Patients with Breast Cancer Survive and Thrive. We have a really great presentation for you, and so let's get started. So a few logistics before we move on to the webinar. As you heard from the announcement, all of our participants are muted during the webinar, and because of that, we are asking you to submit your questions about the content in the question pane, which you will see on your control panel. If you have any technical issues, you can also submit those through that question pane. We have staff standing by to answer those questions and assist you. Questions will be answered as time permits. The presenters have shared or have saved some time at the end for questions and answers, but anything that we don't answer during the webinar will be posted with the answers on our website. We ask you to complete a post-webinar evaluation that you'll receive about an hour after this webinar wraps up. This helps us to improve the content for the next webinar. It also gives you an opportunity to identify any additional topics that you'd like us to cover. So with that, let me go ahead and introduce our moderator for today. I'd like to introduce Catherine Schmitz. Dr. Schmitz is a professor of hematology and oncology at the University of Pittsburgh Hillman Cancer Center, and she is the vice chair of the NAPBC Standards Committee, well qualified to speak on all of these topics. Dr. Schmitz, I'm going to turn things over to you. Thank you.
Thank you very much, Asa. Thank you to you and Chantel and the team for helping us to coordinate and organize this session. So welcome to today's webinar. We are doing this as part of an educational effort on the part of the NAPBC in light of the fact that there are changes to the standards that are coming up, and some of them relate to nutrition and exercise. And we felt because there were these changes to the standards that were intended to reflect better the patient journey, then part of the patient journey is helping them to understand how to survive and thrive, including what they might do for themselves with regard to nutrition and exercise. And so I am absolutely delighted to have on this webinar today Dr. Jennifer Ligabell from Dana-Farber Cancer Institute. She is a breast oncologist, and she has been the leader of a committee through ASCO that has developed a set of guidelines related to nutrition and exercise that she'll talk about today. And very importantly, she also is a leading researcher in the area of lifestyle, exercise, and nutrition in breast cancer in particular. And we will also hear from Dr. Tracy Crane, who is an associate professor at the University of Miami Sylvester Comprehensive Cancer Center. And Tracy is a nutritionist by training, and she I have been delighted to be able to watch Tracy rise from being a fledgling postdoc to being a powerhouse, very well-funded nutritional researcher in the area of oncology. And all three of us are working together on a national initiative called ANICTO that Dr. Ligabell is going to talk about as well. So I am actually the last speaker in the webinar, and what I will be doing is focusing my comments on the places in the revised standards where nutrition and exercise show up, so that you have a sneak peek of what's coming. So without further ado, if I could get Dr. Ligabell to turn on her camera and Asa to start moving the slides.
Great. Thank you so much, Dr. Schmitz. It's really great to be here. Welcome everybody this afternoon. I'm going to spend the next few minutes talking about exercise, diet, and weight management in breast cancer patients. And as Dr. Schmitz said, we'll spend a bit of this time talking about a recent guideline that ASCO has put together related to these topics for patients as they go through cancer treatment. And then we'll finish up by talking about some of the gaps that we identified as we did the literature search for that guideline and ongoing work that's being done to try to fill in some of these missing pieces. So if you go to the next slide, please. Taking a little bit of a step back, why are we interested in exercise, diet, and weight management in breast cancer patients in the first place? And a lot of this goes back to observational evidence that shows us that obesity, inactivity, poor dietary quality are risk factors, not just for the development of breast cancer, but also prognostic factors for individuals diagnosed with early stage, potentially curable disease. This meta-analysis that was published by the World Cancer Research Fund last year looked at 64 different studies that had evaluated the relationship between body mass index and cancer-related outcomes in patients who were diagnosed with early stage disease. And what the investigators found was a roughly J-shaped relationship between body mass index and all-cause mortality that you see on the slide here. If you advance, please. In particular, they found a strong relationship between body mass index and the risk of breast cancer-related mortality, such that for every 5 kilograms per meter squared increase in BMI, and that's about the amount of weight that it takes to go from being normal weight to overweight or overweight to obese, there was a 10% increase in the risk of breast cancer-specific mortality and a 14% increase in the risk of second breast cancers. If you go to the next slide, please. We also know that physical activity and fitness are related to outcomes in women with early stage breast cancer, as well as other cancers. On the left-hand side here, you see an analysis that was done by some of my colleagues at the Brigham, looking at cardiorespiratory fitness at the time of cancer diagnosis and the risk of cancer-related mortality. If you advance it twice, please. I'm sorry, I didn't know I wasn't advancing. Actually, all right. I won't do it. So what the graph on the left shows is that individuals with higher cardiorespiratory fitness had a lower risk of cancer-related mortality in the years after the diagnosis of an early stage cancer. On the right-hand side are data looking at the relationship specifically in post-diagnosis physical activity patterns in cancer-related mortality. If you advance one more time. And what this demonstrated was that in individuals with breast cancer, with colon cancer, and with prostate cancer, the amount of exercise that they did after being diagnosed with their individual cancers was related to their risk of cancer-related mortality, such that individuals who were more active had a more than 30% lower risk of dying from malignancy compared to individuals who were inactive. And so these were the kinds of data that led to the development of the ASCO guideline. If you go to the next slide, please. The goal here, and advance again, I apologize for all the advances. The goal here was to look at the evidence that suggested that changing somebody's exercise patterns or their diet or helping them to lose weight or avoid weight gain during treatment would have an impact on cancer-related outcomes, treatment-related outcomes, or things like quality of life. If you want to go to the next slide to kind of break down a little bit more specifically in what we were trying to do, the guideline specifically focused on adult patients who were undergoing active treatment with chemotherapy or radiation, or who were in the perioperative period. So this was not a guideline that focused on children, that focused on post-treatment survivors, but really trying to fill in a gap in knowledge about what should people be doing during their active treatment or immediately before or after surgery. If you advance twice, please. The next part that's important to recognize about this guideline was that it specifically looked at interventional studies. We just looked at some very important observational data showing the link between obesity and cancer recurrence and mortality, and looking at physical activity patterns. This guideline really specifically focused on interventional studies, looking at helping people exercise more, changing their diet, or changing their weight in a meaningful way, because it was designed for oncology providers who were looking at a patient across the room and saying, well, what should I do during my treatment? So this guideline was specifically developed to answer that question, rather than looking at patterns of weight and exercise and diet and how they were related to long-term outcomes. If you go forward 2 more times. Once, thank you. And then the last piece that's important to recognize about this guideline is it was specifically looking at outcomes related to treatment. Did people finish their treatment? What kind of toxicity did they experience during their treatment? Was there an impact of these interventions on disease recurrence, on long-term quality of life, on second cancers? So it wasn't a guideline that was looking at, can we help people make these changes, but rather, what kind of benefits could people expect if they increase their exercise, if they change their diet, or if they tried to lose weight during their cancer treatment? If you go to the next slide, please, which thankfully is not animated. So in terms of methodology, we were primarily looking at systematic reviews or randomized controlled trials that were not included in systematic reviews that included at least 25 subjects per arm. These were all adult patients during active treatment, and they looked at aerobic and resistance exercise, special diets and foods, and intentional weight loss and avoidance of weight gain. Again, the outcomes of interest were things like quality of life, physical function, treatment toxicity, and cancer control, including recurrent, survival, and second cancers. We use grade methodology to assign levels of evidence quality, high, moderate, low, or very low, and this was performed by a project methodologist. You go to the next slide, please. In terms of the evidence base that we identified for this guideline, we searched PubMed and the Cochrane Library for publications between 2000 and 2021, so a 21-year period of time. We identified 52 systematic reviews and 23 additional randomized controlled trials that were not included in the reviews. Notably, 42 of these systematic reviews focused on exercise. So clearly there was a lot more evidence about the implementation of exercise interventions during treatment than there were for the other types of factors that we were looking at. There were 9 systematic reviews for diet and only 1 for weight management. Notably, although this guideline did not specifically focus on breast cancer, more than half of the studies that we included focused on women with breast cancer. And there were also a number of studies in individuals with prostate cancer, lung cancer, and colorectal cancer. If you go to the next slide, please, and advance again. So the top level recommendation from this guideline was that oncology providers should recommend aerobic and resistance exercise during active treatment with curative intent. If you advance again. The rationale for that was that the evidence that we reviewed clearly demonstrated that exercise interventions during active treatment reduced fatigue, preserved cardiorespiratory fitness, physical functioning, and strength. And in some populations, and I think very relevant for our call today, because most of these data, again, were collected in breast cancer patients, that exercise during treatment improved quality of life, reduced anxiety, and reduced depression. If you advance again. Now, the evidence quality overall was moderate to low. There was a lot of heterogeneity, but because of the lack of harm and the sheer volume of evidence that we'll look at in a minute, our recommendation, our strength of this recommendation was strong. If you go to the next slide, please. So this is just an example of one of the many evidence tables from this guideline looking at the value of exercise in patients receiving treatment. So what we did was we looked outcome by outcome at the number of patients that were included in the studies, in the effect estimates, and in the certainty of the evidence. And if just to highlight a couple of these, if you advance again, looking at VO2 max, for example, there were 13 different studies that evaluated this in patients currently receiving therapy, including 1,318 participants with moderate quality evidence. If you go to the next, fatigue is another example where there were many studies, 21 different trials, almost 2,000 participants, again, showing moderate quality evidence. So I'm not going to go through this in detail, but there were thousands of patients that were included in this evidence review looking at the value of exercise during treatment. If you go to the next slide, please. The other thing that we really looked at, well, is exercise safe during treatment? And is there enough evidence to really evaluate any potential dangers of this in patients as they receive chemotherapy, radiation? And what we found was that overall, the frequency of reporting adverse events across studies was variable, but rates of exercise-related AEs were low. The literature identified 11 different systematic reviews and meta-analyses that reported exercise intervention-related adverse events during cancer treatment. And here you see probably the largest of these was a study by Scott et al. That looked through 14 different trials and found that there were only 11 adverse events that were reported across these studies. So our overall estimation was that exercise, in addition to having the many benefits that we just reviewed, was also safe for patients during standard chemotherapy and radiation treatments. If you go on to the next slide, please. So we next turn to diet and weight management recommendations. And if you advance, and unfortunately, as opposed to exercise, where there were so many studies looking at the value of exercise interventions during chemotherapy and radiation, there were very few studies that looked at dietary change, and we ultimately had to conclude that there was insufficient evidence to recommend for or against dietary interventions during treatment. If you go to the next, if you advance again, please. The one thing that we did see consistent evidence that neutropenic diets, in particular diets that advised against fresh fruits and vegetables during therapy, did not seem to have benefit, and we recommended against the implementation of neutropenic diets. This is less common in breast cancer patients, but in fact did not see value of omitting raw fruits and vegetables, even in patients receiving stem cell transplants. If you go on to the next, there we go, and sorry, one more advance. We also unfortunately found very little evidence looking at the potential benefits of weight loss interventions during cancer treatment. And again, we were not able to provide guidance regarding the incorporation of weight loss or prevention of weight gain interventions during cancer treatment. If you go to the next slide, I just wanted to include an example looking at that large table of evidence for exercise interventions during treatment. When you see that dietary data, it's much less consistent or comprehensive. And so this was one of the tables looking at dietary interventions during chemotherapy or radiation. And you see this was based on only 4 studies, 136 patients, looking at a heterogeneous number of different types of dietary programs, ketogenic diets, fasting, low carb. We basically could not really find any consistent recommendation from this type of evidence. So if you go on to the next slide. So this guideline process, in addition to leading to a very strong recommendation for the incorporation of exercise during cancer treatment, highlighted a number of important gaps in the evidence about what patients should be doing during their cancer treatment to help improve their outcomes. I think we really found that there was very little data for any kind of diet intervention or weight management intervention during treatment, so a huge amount of additional information needed there. We also found there was almost nothing about exercise, diet, or weight management interventions in advanced disease. And despite looking very carefully through the literature, most of the research that we found, even in exercise, really focused on toxicities of therapy and quality of life. And so there was not consistent evidence about the impact of any of these types of interventions on treatment-related outcomes. Did people finish their therapy more reliably? Did they have higher levels of toxicity? And no large-scale studies looking at the impact of these types of interventions during treatment on cancer recurrence, progression, or survival. If you go to the next slide, please. So I just wanted to finish out my remarks by talking about a number of the studies that are ongoing that are trying to fill in some of these gaps. If you advance, please. The first of these is a study that we've been leading in the United States now for a number of years called the Breast Cancer Weight Loss Trial. And this is a study that was really designed to answer the question of whether losing weight, if you're a patient with overweight or obesity at the time of breast cancer diagnosis, will reduce the risk of cancer recurrence and cancer-related mortality. This study is a phase 3 trial funded by the National Cancer Institute that sought to enroll 3,136 women with a BMI of at least 27 who'd been diagnosed with an early stage hormone receptor positive, HER2 negative, or triple negative breast cancer within the preceding year. Patients were randomized to a 2-year telephone-based weight loss program that was delivered through a centralized call center at Dana-Farber, plus a health education program or to a health education alone program. The primary outcome of this study is invasive disease-free survival, and a key secondary objective was weight change, because if people didn't lose weight on the study as a result of the intervention, it would be impossible to determine whether weight loss actually led to improvement in outcomes. If you go to the next slide, please. At ASCO this year, we presented the first weight loss data from the BeWell study, looking at weight change over the first year of study participation in the 3,180 patients who had enrolled in the study. What we found was that patients, and if you advance twice, we can just go through. What we found was that patients who were randomized to the weight loss intervention lost 4.8% of their body weight, or 4.4 kilograms at 1 year. And this was compared to a 0.9% weight gain in the control participation, or a 0.7 kilogram weight gain. And this resulted in about a 5.6% weight loss in the weight loss intervention versus control at 1 year, which was highly significant. We do not have the long-term outcomes in terms of disease control from this study, but we do know that patients lost a significant amount of weight, and we are continuing to follow them. And we'll hopefully have the answer to the question of whether weight loss improves outcomes over the next year. If you advance again, just a quick word about other research that's going on, and I know we'll hear a little bit about this from Dr. Crane as well. There are many other studies that are seeking to answer some of the questions about the value of diet and exercise interventions during and after cancer treatment. This is a large initiative funded by the NCI called the Exercise and Nutrition Interventions to Improve Cancer Treatment-Related Outcomes. There are studies going on in breast cancer, ovarian cancer, colon cancer, and rectal cancer. If you go to the last slide here, sorry, one more. Sorry, do you mind going back? I'm almost done, I promise. So the THRIVE study is a study led by Dr. Schmitz, myself, and Dr. Berger that is seeking to look at the impact of an exercise and protein supplementation intervention during chemotherapy on treatment-related outcomes in older women receiving neoadjuvant or adjuvant therapy for breast cancer. So looking at the amount of chemotherapy that they receive, whether they complete their chemotherapy course, and the toxicity that they experience. So last slide, this is really just a quick overview, lots of observational evidence suggesting that weight, diet, and exercise are important in breast cancer. There's consistent evidence from randomized trials that exercise during treatment improves treatment-related outcomes like fatigue, physical functioning, quality of life. But many gaps remain, and I think this is something that over the next years we hope to fill these in to be able to give you all much more concrete evidence of how you should counsel your patients regarding diet and exercise, both during and after cancer treatment. And I think with that, I will turn things over to Dr. Crane, who will focus more specifically on diet in our breast cancer patients. Thank you.
Thank you very much. That was a great, nice overview and lead in. I'm going to really focus this in now on what the evidence has been to date. As Dr. Ligabell mentioned, they were inconclusive with the ASCO guidelines that were specifically looking at nutrition during treatment. So next slide, please. So I just want to ground us quickly and provide a resource for all of you that I think is a good one. The World Cancer Research Fund does a nice job doing the continuous update project. And when we think about diet and breast cancer risk, especially for our women at increased risk or elevated risk for breast cancer, they have reviewed more than 119 studies from around the world. This is inclusive of 12 million women and more than 260,000 cases of breast cancer. We know that there's strong evidence that consuming alcoholic drinks increases the risk of both pre and postmenopausal breast cancer. There is some evidence that consuming non-starchy vegetables, which are things like carrots and broccoli and cruciferous vegetables, may in fact decrease the risk of estrogen receptive negative breast cancer. We know that consuming foods containing carotenoids, these are things like the things that give your vegetables the orange color, yellow color, and red color, may in fact decrease the risk of breast cancer. Dairy products may decrease premenopausal breast cancer, and diets high in calcium might decrease the risk of pre and postmenopausal breast cancer. Taken in total, it's very confusing, I think, with diet. And I think I can say that when you get into these trials a little more deeply, we'll see that. So next slide, please. So specifically, one of the largest and first trials that was ever really studied to look at the impact of diet on breast cancer was the Women's Health Initiative. And the Women's Health Initiative got a lot of attention because of the hormone therapy trial there at the top. But if we focus in where that arrow is, one of the interventions was actually a diet modification trial. And their primary aim, and they were powered to look at breast cancer development over time. The diet in general was a low-fat diet. It had an increased vegetable and fruit, as well as whole grains. You go to the next slide. And when we looked at the initial 8.5-year follow-up, we saw no significant difference in breast cancer incidence or death from breast cancer. In the subgroup analysis, however, we did see that estrogen receptor and progesterone receptor negative breast cancer did have statistically significant reductions in death after breast cancer. However, death from breast cancer specifically was not significant. And you're going to see this continuing theme throughout my presentation, that when we look at longer term follow-up, we start to see things change a little bit in terms of diet and risk. So significant reduction in deaths after breast cancer did in fact show up after the longer term, almost 20-year follow-up. And at that point in time, breast cancer specific deaths were in fact significant and reduced for women who were in the low-fat, high fruit and vegetable and fiber intake group. Go to the next slide, please. So this is a more recent trial. When we think about diet, we think about also diet patterns. And so diet patterns refers to things, if you've heard, many of you, like a ketogenic diet where you're following a very high protein, high fat diet, or we also study more routinely a Mediterranean diet pattern. And so the PREDIMED trial was looking at a diet and breast cancer risk. It was actually a very large cardiovascular disease trial for both men and women, but they had about 4,200 women also participating, and there were 3 groups. And so if you look at this screen here, it's a little bit small, but you can see this top line was the control diet. Then they had one Mediterranean diet that was really focused on giving them nuts to the families, and then a Mediterranean diet with extra virgin olive oil. And interestingly here, in those who actually had were following either one of the 2 Mediterranean diet patterns over a course of 12 months, you can see they did have a lower risk of breast cancer development. However, when we look at those who were getting the 1 liter of olive oil per week over the 12 months, along with a nutrition counseling, they actually had the lowest risk of breast cancer. You go to the next slide, please. So those are probably 2 of the largest trials that have been had looked at breast cancer risk in terms of a diet intervention. So if we think about what about after a diagnosis of breast cancer, after completion of treatment, what do we know about diet and breast cancer recurrence and mortality? So next slide. So some of you may remember these 2 trials. These from the late 90s, early 2000s. As Dr. Schmitz mentioned, I've been in this cancer space for a long time. I actually was a dietitian on both of these trials early in my career. And when we think about the WINS trial, it was the Women's Intervention Nutrition Study, and the WELL trial, the Women's Healthy Eating and Living trial. These were 2 trials that were running parallel at the same time. The WINS trial was looking at women, about 2,400 women who were within 1 year of diagnosis, postmenopausal, and the focus on this trial was really a low-fat diet. We were asking women to consume 15% or less of their calories from fat. And when we look at the results, there was about a 2.6 between group difference for breast cancer events. However, this was not significant when we looked at follow-up. On the WELL trial, we were also looking at invasive breast cancer. We followed them for about 7 years, and they were really asked to consume a high amount of vegetables. We focused them in on actually juicing. So every woman got a juicer on the trial, and they also consumed 16 ounces of vegetable juice. They had 3 servings of fruit per day, 30 grams of fiber, and 20% of their energy we were counseling them to be from fat. We also gave the control condition recommendations to follow the American Cancer Society's dietary guidelines. And unfortunately, in the WELL trial too, we did see no reduction or improvement in breast cancer events or mortalities. You go to the next slide, please. However, when you start to look at these sub-analyses, things start to change. So on the top slide, you can see that the estrogen receptor positive breast cancer, that was for the WINS diet, really no difference. So when we start to look at estrogen receptor negative breast cancer, we do start to see those curves differentiating, and we did in fact see a difference in a reduction in breast cancer recurrence in the estrogen receptor negative women. For the WELL trial, this is a sub-analysis that's looking at women who were only in the control condition, and those were their baseline levels of plasma carotenoids. So remember, those were the things that's an objective measure of fruit and vegetable intake that we can look at. And you can see we separated them into quartiles, and those, the blue line there at the top, are the women who are in the highest quartile for carotenoid intake. So we know they had a very high level of vegetable intake, actually did in fact have a reduced risk for any new breast cancer event. Next slide, please. And just out, hot off the press last week, I think, is the Diana-5 trial. This was a trial in 1,500 women with elevated risk for breast cancer reoccurrence, and they defined this as being stage 1 to 3 due to estrogen receptor negative cancer or having metabolic syndrome or high plasma levels of insulin or testosterone, and they needed to be within 5 years of treatment completion. They were randomly assigned either an active dietary intervention or a control for 12 months. They had a 5-year follow-up. Both groups were given the dietary recommendations by the American Institute for Cancer Research. The intervention included cooking classes, group education, community meals, really focused again back on that Mediterranean diet pattern. And then they had an a priori diet index that they designed to measure the difference between the foods that they were recommending to follow the Mediterranean diet pattern versus foods that they were discouraging. And I want to emphasize all these trials, we don't have enough time to dive into them, but they were all offered at various intervals and different frequencies. In my mind, I would classify this as a lighter touch intervention trial. If you go to the next slide, please. And what we see, again, these survival curves looks really similar across all these trials when we do our first, global look at their results, but we saw no impact on recurrence of disease. In fact, the hazard ratio was 0.99. If you go to the next slide. However, when they looked at that diet index that they created, and we start to look at tertiles of this diet index, you can see those in the highest group see some benefit with recurrence-free survival versus those in the lowest tertile of a diet index. And so, and you can see here, I just have, we go to the next slide. We're almost done here. So I just want to hone in because I think Dr. Ligabel did a great job of showing that, demonstrating we need more trials during active cancer treatment focused on diet. So go to the next slide. And when this is called the direct trial. This is a little bit smaller trial, but I think it's important as we start to think about in our knowledge and science evolve with what we know about different diet patterns and meal timing. So this is with women with HER2 negative, stage 2 or 3 breast cancer. They had planned neoadjuvant chemotherapy. They were assigned either a fasting mimicking diet, which is a very low calorie diet, versus a usual diet for 3 days leading up to their chemo cycle or the day, including the day of chemo cycle. And interestingly, this fasting mimicking diet had higher odds of a radiologic complete response as well as a pathological complete response. And they saw no differences in treatment toxicity between the two groups. If you go to the next slide. And some of these results have led us to actually start our new R01 trial, which is with Dr. Ligabel, myself, and Dr. Daly Conwright. And this is really looking at prolonged overnight fasting in the metastatic space. So women who are newly diagnosed with metastatic breast cancer and are starting a CDK4/6 inhibitor. And we are really looking to try to realign circadian rhythms with prolonged overnight fasting and exercise, with the primary outcome being focused on fatigue. If you go to the next slide. So, back a little bit. So this is a 2x2 design. I'll just be very quickly about it. It's a 2x2 design. They either get fasting alone or in combination with exercise, or exercise alone or in combination with the fasting. It's a 12-week intervention and really focusing again on trying to align circadian rhythms with both the timing of meals as well as the timing of exercise. And then this is my last slide, I believe, close. And so I think it's important. I mean, if you take away nothing from this, I think it's clear that it's difficult to measure diet. Study design needs to be carefully considered and follow up. How long should we be following these women? A lot of times it took a very long time beyond the traditional 5-year grant cycle to in fact see the changes that emerge from these dietary interventions. Diet's complex and we can measure that a number of different ways. We can look at your eating patterns, your meal timing, different nutrients, carotenoids, and I really think we're on the cusp of trying to understand not only the metabolism of the individual as a person at a system level, but also at the tumor level and what's happening. So I think in the future, we're going to start to see hopefully more in the space of environmental and gene interactions. Go to the next slide. And so finally, I think the summary is that we need more research focusing on all these things. And with that, I'm going to turn it over to Dr. Schmitz to wrap this up.
Okay, fantastic. Thank you both very, very much. Thank you, Dr. Crane. Thank you, Dr. Ligabell. So my task was to take all that evidence base that you've just heard and to show you what we did with the revision of the NAPBC standards. And I was really honored to be on a small group that really did a lot of careful thinking about how best to revise the standards. And obviously, as an exercise oncology researcher and advocate, I did my share of advocating as we went through this process as well. Next slide. There we go. So as an overview of what I'm going to talk about, I'm really now focusing on the new standards, the revisions that are intended to focus on that patient journey. I will note that these new standards have been piloted in 2023, and it is my understanding presently that the new standards will go into effect as of January 2025. It says 2024 on the book. That's when they become live, but you know, things take a while to go into effect. So next slide. So the patient journey change. This is a slide that I took directly out of Jill Dietz's slide deck to talk about the patient journey. And the idea behind the standards revision, which was extensive, was that the old model, if you will click forward once. No, oh no, go back. Okay, there's some things missing from the slide. Oh well, go back to the planets. So the things that are missing from this slide had, you know, basically NAPBC was sitting as the sun, and the centers and the patients were out in the you know, Pluto and Saturn range. And in the new version, if there were the animations here, I don't know what happened to them, we are putting the patient and you all in the center and NAPBC out near the Pluto and Venus range. Next slide. We also wanted to really recognize the fact that you know, the people that we're trying to serve with these standards are living, breathing human beings who are going through an intense emotional experience through their breast cancer journey. Click forward one time, there should be an animation. There we go. So this breast cancer journey obviously is not a straight line. And one of the things that you'll read, if you read some of the captions on this slide, are about the connections that are missed, that are most difficult for women to deal with as they go through, and the waiting for things that, you know, makes a real difference. And so you'll see some of the patient in the revised standards. You'll see some of the issues that we tried to address in addressing the patient journey in the revisions to the standards. Next slide. So this is really a paradigm shift. The idea is that this is intended to be breast care through the patient lens, and it was intended to come into alignment with the American College of Surgeons' emphasis on value-based care and the Commission on Cancer's cancer care goals. The standards are intended to help provide high-value patient care that is feasible, educational, and not punitive. And I want to focus on that last word of punitive. One of the things that we kept hearing from members of the small group that did a lot of the work in making the revisions is that we wanted to get away from the idea of sort of bean counting, or, do you have, you need to have 25% of something, or 75% of patients in the medical record review must have, that kind of language. We were more interested in process, and we were much more interested in partnering with sites in order to help them to provide the best quality care that they can based on the available resources in your particular center. And so they were really intended to shift to be more educational and to point centers towards the best that they can do. They are intended to be adjustable and fluid, and there's intended to be an adjustable, fluid, long rollout period so that programs can adapt and grow, because the magnitude of the changes in the standards is admittedly large. Next slide. So what I'm going to go through is literally I did a search and putting together these slides for the word nutrition in the standards, and then I did the same thing for exercise, and I want to walk you through all of what the standards say on these two topics. For nutrition, the first time we see this appear is in Standard 2.3, which is just description of the breast care team. Nutritionists are specifically called out as being among the healthcare professionals appropriate for both the breast program director and the breast program leadership committee to include within the breast care team. It is not a requirement, but they are appropriate to be included. Next slide. In Standard 5.7, which is a comprehensive evaluation of patient factors before treatment begins, there is a requirement that each calendar year, the breast program leadership committee must review and assess one of multiple possible categories of patient pre-treatment evaluations. And there are a number of possible pre-treatment evaluations that could be evaluated and reviewed by the breast program leadership committee. One of them is evaluations for referrals to nutrition counseling. Next slide. In the standard for medical oncology, Standard 5.11, protocols must be developed and implemented for assessment of side effects of systemic therapy and appropriate referrals and interventions. There are a number of things that are noted as possible interventions to address side effects during treatment, including nutrition support, which can be offered to patients to maintain a healthy diet while experiencing the side effects of chemotherapy. Note the wording of that particular bullet point is very careful not to disagree with the conclusions of the ASCO guideline. So it is not saying necessarily that that there is a particular diet, but to maintain a healthy diet while experiencing side effects. Next slide. Now I'm going to switch to exercise. The first place that exercise appears within the new guidelines is again with Standard 2.3. Like with nutritionists, exercise professionals are specifically called out as being appropriate for the breast care team, not required, but appropriate. If the breast care team is being put together and the leadership is deciding who should be on this team, it would be appropriate to have both exercise professionals as well as nutritionists. Next slide. Within that Standard 5.7, which I mentioned before with nutrition in the comprehensive evaluation of patient factors before treatment, there is the requirement of review of multiple possible categories of patient pre-treatment evaluations and evaluations of referrals for exercise programs and physical therapy are included as a possible category. Next slide. This is a new one and a fairly innovative approach that we talked a lot about. There is now within standards 5.9, 510, 511, and 512, which are surgical care, reconstructive surgery, medical oncology, and radiation oncology. There is a requirement that a protocol must be developed for pre-treatment functional assessments and appropriate referrals to exercise, physical therapy, or lymphedema management. You need to have a specific protocol that you develop for functional assessment. We do not prescribe what that protocol is, but we do provide an example of what would be responsive to this standard. And I'll show you that in just a second. But I want to say before we go to the next slide that the same protocol can be used for pre-treatment functional assessments for all 4 of these standards. So whatever you come up with can be used in all of these settings. The idea is that we're doing pre-treatment functional assessment of every patient before surgery, before reconstructive surgery, before chemotherapy, and before radiation therapy. The idea behind this is to make sure that the person has the functional capacity to be able to withstand whatever treatment you're about to undertake with that patient, and to make sure that it is possible for them to benefit from the therapy you're about to offer. For example, if the person does not have sufficient range of motion to put their hand up in a position that would be necessary for radiation treatment, you need to know that before you start radiation treatment so that you can refer them to physical therapy so they can get the range of motion they need. So that's just as one example. Now, next slide. The recommended functional assessment protocol is will take 15 seconds, and there are 2 tests that are recommended. They're both objective tests. One is arm abduction, just simply asking the woman to raise her arm up over her head and back down, and the other is the timed up and go test. These are provided in an appendix. The timed up and go test, as I'm showing it here, it's probably like 2-point font for you, but very easily found. If you Google for timed up and go and CDC, you will get this exact page. And there's a way of scoring it. And if the person can't get up out of a chair, walk 10 feet, come back and sit down in 12 seconds, then you need to consider whether they have a functional impairment that is large enough that you need to do something before they receive whatever treatment you're about to offer them. This is one example. This is not the only way to do this. If you are a center that has physical therapists embedded within your practice, the physical therapist can do the evaluation. If you don't have the capacity to do this, you can do a self-report instrument that's a validated instrument. Those are available. So there are a variety of ways to meet this standard. And one of the things that I was really sensitized to in this process of the revisions of these standards was being aware that centers vary tremendously with regard to personnel available and time available. And so we got this down to 15 seconds. And I think that's pretty short. So I hope you all agree, and I'm happy to take any questions that you have about it. Next slide. Okay, so in standard 5.11 medical oncology, there is a recommendation, or not recommendation, a standard that patients with breast cancer must receive the following care with documentation in the medical record. They obviously need to have guideline and evidence-based care. They obviously need to have their pre-treatment functional assessments and referrals that we just talked about. But there is a new bullet here that exercise therapy recommendations must be made as well for control of the very same symptoms that were reviewed by Dr. Ligabell in the ASCO guideline process. The site reviewer will evaluate pre-selected medical records to confirm compliance with the standard, including exercise therapy recommendations. So a couple of things to note here. One is, yes, there is going to be a requirement that words come out of your mouth and you say something about exercise, right? It can be, I think you should go for a walk more often for your cancer fatigue, and then you type in the medical record, exercise recommended. So it can be that simple, but there does need to be something said to the patient. If you are a center that has an exercise oncology program on site or in your community, you can make a recommendation to go to that. There are online programs that are available for exercise oncology. You can refer people to that. There's actually an app now in the App Store, both Android and iOS, called Cancer Exercise, developed by a well-known exercise oncology researcher, Anna Schwartz. She's an oncology nurse. And so you can go point people to Cancer Exercise in the App Store. So there are a variety of ways. Again, there were many discussions, again, in the team that developed this guideline or this standard. There were many discussions about the many different varieties of resources available and not available to a variety of accredited centers. And so be very clear that the word here is exercise therapy recommendation, not that you have to have a program necessarily. If you have a program, great, you've got a program, you need to recommend, refer people to it. So the recommendation could be go to our program. And that would be a way of meeting this standard, and that would be great. But we do recognize that not every center not every program is going to have a program on site. And so that's why the word recommendation is very specific. Next slide. And then finally, in the area of survivorship, it is required in the standard that NAPBC accredited programs use evidence-based guidelines to develop and implement protocols to address persistent symptoms, functional issues, and social and behavioral determinants of health. And examples of evidence-based guidelines include referral to online or local exercise programs and referral to outpatient rehabilitation. So the continuation of wanting you to make referrals to appropriate programming continues through the survivorship timeframe. Next slide. So one last comment from the standard 5.15 survivorship. There is, again, there has to be this protocol for addressing symptoms, functional issues, and social behavioral health issues. And one example that is given is ensuring that breast cancer survivors receive referrals to exercise programming at follow-up appointments. Next slide. So in summary, the new standards highlight nutrition and exercise in a way that is intended to support the patient journey, to reflect the evidence base supporting their inclusion in breast care, and recognizing that what sites will have available to them will vary widely. And so we have worded them very carefully to make sure that it is possible for you to be able to comply. I believe that that is the last slide. And Asa, do you want to say something about the conference?
Yes, happy to do so. Thank you, Catherine. So I wanted to mention that we will be offering a cancer conference, including 2 workshops in February of 2024. From the 22nd to the 24th, there will be a QI workshop on the afternoon of the 21st, an NAPBC workshop on the new standards in the morning of the 22nd, and then the conference will begin on the afternoon of the 22nd and wrap up around 3 p.m. On the 24th. We are covering information throughout cancer programs. That's all of our areas: AJCC, cancer surgery standards programs, COC, NAPBC, NAPRC, plus all of the other acronyms that we have within cancer programs. So we've got the email address here, not the email, but the URL address here. Feel free to check out the agendas that are posted on our website, and we hope to see you in Austin in February.
Okay, so I think we have a little bit of time now for questions. And so somebody said, asked about the second assessment. And so the timed up and go is one of the assessments. The other assessment is the arm raise, basically. Shoulder abduction is what it's called. That's it. That's the entirety of the assessment. Just making sure that women can get their arm up over their head. I'm having difficulty, Chantel, seeing the questions. I can only see one question. I do have 2025 start. Our understanding was 1/1/2024. You know what? I am afraid I'm going to confuse people if I answer this question. So I'm gonna point you back to your site reviewers and leave it at that. But Chantal, I know there are questions there, but I can't quite open the window to be able to see them. Do you see other questions?
Yes, actually, I just sent them all to you. They should be popping up for you.
The only one that I see right now is the 2025 start. There we go. Are the breast cancer patients truly interested in changing diet or exercise while being treated? How does treatment-related fatigue impact enrollment in an exercise or dietary program? Oh, I've got an answer for this one. So at Hillman, we've been doing a triage and referral system that asks patients about their symptoms and side effects to see whether or not, if they have symptoms and side effects, if they're interested. And 45% of patients agree to be referred into an appropriate program, whether it's outpatient rehabilitation or an exercise program. So I would call that a robust response. So I've got that one. Tracy, do you want to answer that for nutrition? You're on mute.
There we go.
Still.
Sorry, somebody had muted me. I couldn't unmute myself. So I think that women, generally speaking, it's teachable moment is what we like to call it, right? So I think actually women are fairly interested. I know at Sylvester programmatically, we have the ability to assess women and what their nutrition factors are when they come into the clinic. And I would say over 70% of them are in fact interested. I think the issue is having the right programs like Katie outlined or Dr. Schmitz outlined, that we really need to have programs available to refer people to, because I do think the interest is there.
And Jennifer, what's your experience as an oncologist? Are they interested?
Asking about what to eat is probably the most frequently asked question that I give during my clinic visits with patients. And unfortunately, that is the area where we probably have the least amount of evidence-based information to share with people, especially during treatment.
And I think that the evidence is challenging to interpret, as I tried to illustrate today. I mean, I think that it's not that diet is a lost cause. I think that it's challenging to study. And I just think that you have to, we know that there's no harm in people following these healthy diets. And I think that's the message we have to get across.
I will say, though, that in my own clinical practice, I get asked a lot fewer questions about a healthy diet than sort of more kind of trendy diets. And I think this is one of the things that's challenging is often dietary trends move much more quickly than dietary science. And so by the time that we get studies looking at a particular dietary component, ketogenic diet, gluten-free diet, people are on to kind of the next thing. So I think that's one of the reasons why I'm so happy to see that there are a number of fasting related studies going on, because that is a question that I get asked all the time, is about intermittent fasting, overnight fasting, fasting mimicking. Again, I don't think that most of these more extreme diets are things that people should attempt before we have more evidence, because I do think that there's a possibility of harming yourself, especially during treatment, if you adopt a very kind of extreme dietary pattern.
Yep, I would agree.
So there was a question about whether the slides will be available, and my understanding is that this is being recorded, so I think the recording will be available. I'm not so sure about the slides. Okay, I am trying to see the other questions and it's just stuck. So there we go. Will the conference be available online? Yes. I know there are a lot of questions.
Actually,
here.
I want to interrupt. I wanted to interrupt real quick. So the conference will not be available online. It's only in person only. And the slides will be posted on our webpage. So in 1 hour, when everyone receives the recording, you will receive the webpage link to where the slides will be posted at.
Okay. So there's one last question. I see it's 2 o'clock, but who can we find out about when we are to be compliant if we don't have a current surveyor The forum continues to say updates are coming and templates and final standards, but no details of when. I can tell you that the executive committee met this week and finalized some things, and I believe that a next version of the standards should be available relatively soon. Thank you for your patience about that. Okay, we're over time. Thank you all very much. Dr. Ligabell, Dr. Crane, thank you very much for spending an hour with us. And thank you to the attendees. Thank you so much to Asa and Chantel for their help in organizing this. And thank you to the Education Committee for the opportunity. All right. Have a great day, everybody. Bye.
Thank you. Bye.